everyone, Dr. Hefferon and Dr. Krutowski here again. We are going to, now we took care of the shoulder, we're going to slide down to the forearm and the hand. So this is really our trail number one. We're going to call it Knob Hill. We might actually see if Dr. K can actually move a little bit and sit a little bit at an angle, so that way we can see a little bit better of what we're talking about. So we're actually going to start with the olecranon process. So you can see that's that bony prominence, and if you have your patient or your partner flex and extend, just go through and see what happens at that olecranon and kind of feel the different ridges around the area. Maybe palpate even with your thumb and your fingers on the opposite sides to see. You'll start to feel in there, if you place your hands lightly, that there is a lot of tendons and nerves and fascia that are very superficial. And so a lot of injuries can come because especially that ulnar nerve gets exposed in that area. So if we're on the olecranon process, if you slide just a little bit superior to that, and if you resist into
elbow extension.
Yep, elbow extension. You should feel that triceps, as the triceps brachii comes down and inserts, that triceps brachii actually pops into your hand. So if you ask your patient to relax, that little ridge in there is called the olecranon fossa. So go ahead and slide your hand in there, and then as your patient goes through full elbow extension, full elbow flexion, find out how that fossa starts to disappear, becomes prominent, and then disappears again. Okay. As you slide off of that, if we slide a little bit more medial, we slide off of the olecranon, go a little bit medial. That groove that you're going to sit in is called the cubital fossa. So very important for us as clinicians to know that which nerve, Dr. K, goes through there?
The ulnar nerve.
The ulnar nerve goes through there. And as we palpate that, we want to just slide just a little bit off of that. You can come from the more medial aspect, slide off of the epicondyle, and slide into that groove as well. Very, very lightly, just strum your finger through there and just see if you can start to feel. A nerve feels like a very thin strand, so it feels a little different than a tendon, feels different than a ligament does. But really, if you're on it, your patient might even start to report that they're feeling sensations down into their hands. So be gentle with your patients as you do that.
It can be very uncomfortable.
Very uncomfortable. So if we're there, we've hit the cubital fossa. We're going to talk about the epicondyles. So we know that the humerus comes down and it forms into two different epicondyles as we move down there. The medial epicondyle, so if we move from, just to get your bearings, olecranon, then we went into the cubital fossa, then this most medial prominence that you're going to feel is the medial epicondyle. Very important, because what inserts into there are flexors of the forearm attach into there. So, and we'll notice that a lot of pain that we get, it can be because of those attachment sites into that medial epicondyle. Okay, so if we go back to our olecranon and we shift out laterally, now we're going to go onto the lateral epicondyle. Again, if you start to feel, if you take your forefinger and you put it onto your lateral epicondyle and your thumb on the medial epicondyle, you'll feel that the lateral epicondyle is smaller. So if we know that the flexors insert on the medial side, what would we expect our insertions to be? It will be of all of our extensors that come up into there. And again, that can be a source of a lot of tendinopathy, tendinitis, maybe even some entrapment in there. So we just want to know that clinically, that's kind of an important landmark for us to realize.
Great.
Great, and I think we've hit them all.